Good morning. This is Diane Stelz, and my case study is on diabetes type 1. This is the patient, Susie Chang. Susie is a 15-year-old freshman student in high school. She is Asian American. She lives with her parents and younger brother, Bobby. She is very active and is a starter on the varsity volleyball team, and as a freshman, that is a lot of pressure to maintain. She does well in her classes. Her past medical history is uneventful. She has had recent strange complaints, according to her mother, of frequent thirst, frequent urination, increased hunger, weight loss, and fatigue. She practices 4 evenings per week and participates in approximately 2 to 3 games per week, some of which are away games requiring travel time. Meals are somewhat irregular due to Susie's volleyball practice and game schedules. She eats lunch in the school cafeteria daily. Susie's chief complaints, in her own words, are, "I've been so thirsty and hungry. I haven't slept through the night in 2 weeks. I have to get up a couple times a night to go to the bathroom. It's a real pain. I've noticed some of my clothes are getting loose. My mom and dad think I might be losing weight, and I'm really not trying." This is what is seen on physical examination of Susie. Her general appearance is she's a tired appearing adolescent female. Vital signs: temperature 98.6 degrees Fahrenheit, blood pressure 124/70, heart rate 85, respiratory rate 18 breaths per minute, and all of which are within normal limits for a 15-year-old girl. Her heart is regular rhythm. Heart sounds are normal with no murmurs. Head, ears, eyes, nose, and throat are non-contributory. Genitalia is normal adolescent female. Her neurologic status is alert and oriented. Extremities also non-contributory. Skin, smooth, warm, and dry. Excellent turgor, no edema. Her chest and lungs are clear. Peripheral vascular, pulses 4+ bilaterally, warm with no edema. And abdomen non-tender and no guarding. These are Susie's initial labs. I made the abnormal labs red so they stand out for you. Her prealbumin is elevated at 40 milligrams per deciliter due to the decrease in fluid volume related to frequent urination causing dehydration. Her osmolality, which is the concentration of solution expressed as the total number of solute particles per kilogram, is 304 millimoles per kilogram of water. Again, this is due to the decrease in fluid volume and dehydration. Her glucose is 342 milligrams per deciliter, and in diabetes, the reason for this abnormality is due to the inability of the cells to take in glucose because of the lack of insulin, leaving the sugar circulating in the bloodstream, causing the hyperglycemia, frequent thirst, frequent urination, increased hunger, and this can cause a decrease in pH, leading to ketoacidosis. Her BUN is elevated because of the elevated glucose level and dehydration. And lastly, her hemoglobin A1C is grossly elevated at 10.5% because of the increase in glucose binding to the hemoglobin, which can, over time, lead to diabetic complications such as eye disease, like diabetic retinopathy, heart disease or coronary artery disease, kidney disease, nerve damage or neuropathies, cerebral vascular damage leading to stroke. So what is our admission diagnosis for Susie? I know we've already talked about it. It's not a big surprise, but we're going to diagnose Susie with diabetes type 1, known as juvenile diabetes or insulin-dependent diabetes. And her signs of polyuria, polydipsia, polyphagia, and involuntary weight loss are key and classic signs that every clinician should know. When we diabetes, we often think of obesity, But with type 1 diabetics, this is not the case. As you see, Susie is a normal weight and height for her age, and her height is just below the 25th percentile on the CDC growth chart. So what kind of treatments is Susie going to need to help her through this? Well, pretty much the treatment for diabetes type 1 is insulin. There are multiple types of insulin sold in the United States. These insulins differ in how they are made and how they work in the body. For Susie, she was started on Humalog and Lantus. Insulin is administered via sub-Q injection and is absorbed directly into the bloodstream. The variability of insulin absorption is associated with blood flow differences at the various sites of injection, such as the abdomen or thighs. For regular insulin, the absorption from the abdomen is better than other subcutaneous sites. The onset, peak, and duration of effect vary among insulin preparations. Insulin pharmacodynamics refers to the metabolic effect of insulin. Commercial insulins are categorized by rapid-acting, short-acting, intermediate-acting, and long-acting. The kidneys and liver account for most of insulin's degradation. By having patients self-monitor their blood glucose frequently and write them down, they can better appreciate their own specific needs for insulin and diet changes. Insulin, a polypeptide hormone dissected from the pancreas, is responsible for the uptake of glucose into the cells for the glucose to metabolize. The polypeptide hormone stimulates the synthesis of glycogen, lipids, proteins, and stimulates the transport of potassium and magnesium into the cells. Mostly in use currently are genetically engineered insulins whose structures are identical to that of the human insulin. The porcine and bovine insulins play a marginal role now. So the pharmacology of insulin. Susie has been ordered Humalog and Lantus. So Humalog is the red line on this chart, and Lantus is the yellow line on this chart, and we'll talk about them individually. Lispro or Humalog insulin is classified as a rapid-acting insulin and begins to work about 15 minutes after injection, peaks in about an hour, and continues to work 2 to 4 hours. Given subcutaneously, usually with meals, and often used in conjunction with carb counting to cover the amount of carbohydrates that increase the blood sugar. Lantus is classified as long-acting insulin and reaches the bloodstream several hours after injection and tends to lower the glucose evenly over a 24-hour period. Given subcutaneously once daily at the same time every day to maintain a steady glucose between Humalog doses. The combination of these two insulins working together will help Susie to maintain adequate blood sugars throughout the day. Hypoglycemia is the main issue, especially with intensive treatment. Disproportionate doses, insufficient calorie intake, or physical exertion are possible triggers for hypoglycemia. Early symptoms and signs of hyperglycemia include hunger, restlessness, sweating or vertigo, unsteadiness, and thought disorders. Considerable weight gain can often be detected under the increased treatment with insulin. Adolescents, especially girls, often realize this, and that to lose weight, all they have to do is stop their insulin regimen, which can become a dangerous practice. And the last medication we're going to talk about is the glucagon emergency kit. Glucagon is classified as a glucose elevating agent and is also an emergency medicine used to treat severe hypoglycemia in diabetic patients who are treated with insulin. And if they've passed out and they cannot take any sugar by mouth, this is what is used. Family and friends of the diabetic need to understand when and how to use this product. Glucagon is a peptide hormone produced by the alpha cells of the pancreas. It works to raise the concentration of glucose in the bloodstream. Its effect is opposite of that of insulin, which lowers the glucose. It is administered also subcutaneously. The patient should become conscious in less than 15 minutes after injection, but if not, a second dose may be given. Get the patient to a doctor or hospital emergency department as soon as possible because being unconscious too long can be detrimental to the patient. When the patient is conscious and can swallow, give her some form of sugar, juice, or whatever you would normally give. The patient or caregiver should continue to monitor the patient's blood sugar for about 3 to 4 hours after the patient regains consciousness and checking them every hour. So on this slide, we're going to talk about hemoglobin A1C with estimated average glucose and what that means. Hemoglobin, a protein that links up with sugars such as glucose, is found inside red blood cells. It carries oxygen from the lungs to all the cells of the body. Glucose enters the red blood cells and links up or glycates with molecules of hemoglobin. The more glucose in the blood, the more hemoglobin that gets glycated. By measuring the percentage of hemoglobin A1C in the blood, you get an overview of your average blood glucose control for the past few months. The doctor should measure A1C levels at least twice a year, more often until they become stabilized. Your healthcare provider may report your A1C results as estimated average glucose, which directly correlates to your A1C. Estimated average glucose may help you understand your A1C value because the estimated average glucose is a unit comparable to what you see regularly through self-monitoring on your meter. A1C is reported as a percent, and estimated average glucose uses the same units of milligrams per deciliter as your blood meters. However, estimated average glucose is not the same as the glucose level on your readings on your meter, because people with diabetes are more likely to check their blood glucose more often when they are low. For example, first thing in the morning and before meals. The average of the reading on their meter is likely to be lower than their estimated average glucose. Monitoring measures your blood glucose at one moment in time, whereas the estimated average glucose of the A1C represent the average of your glucose levels 24 hours a day, including times when people are less likely to check their blood sugar, for example, after the meals. Susie's teaching needs. Susie's teaching, which must include her family, will need to be multifaceted. She must understand her diagnosis of diabetes and what it means to her and her body. Of course, her medications and the injection process are also needed, and healthy eating and the maintenance of exercise in her life. But there are things she and her family need to watch for, and the best way to avoid some of the associated problems with diabetes are to know what causes them and how to prevent them. I'll discuss concepts in a bit, but from day one, it is very important to empower Susie with the knowledge she needs to manage her diabetes and to learn to achieve self-maintenance. Carbohydrate counting, hyperglycemia, hypoglycemia, ketones, ketoacidosis, and more are dependent on the choices of the individual and can also create the concept of glucose regulation. Pathophysiology of diabetes. This is a quick comparison of type 1 and type 2 also. Type 1 diabetes is a metabolic condition resulting from the destruction of pancreatic beta cells, leading to a loss of insulin production or an absolute insulin deficiency. Insulin is a hormone necessary to facilitate movement of glucose into the cells for metabolic activity. The cause of type 1 diabetes is unknown, but it may be associated with an autoimmune response with genetic predisposition. It requires lifelong insulin replacement therapy. Children with type 1 diabetes are often thin or of average weight. Susie is smaller build, and her Asian American heritage makes her slightly less predisposed to diabetes than those with Native American, Hispanics, or non-Hispanic Blacks. Type 2 diabetes is characterized by features of insulin resistance paired with beta cell failure resulting in hyperglycemia. Chronic hyperglycemia leads to complications of retinopathy, nephropathy, neuropathy, and cardiovascular disease. Previously common in adults only, type 2 diabetes is now seen in children and adolescents due to the increasing rate of obesity in this population. Many of those with type 2 do not require the use of insulin and use oral hypoglycemics. This is approximately 95% of the diabetic population. Understanding diabetes type 1. An understanding of the pathophysiology of diabetes rests upon knowing the basics of carbohydrate metabolism and insulin action. Following the consumption of food, carbohydrates are broken down into glucose molecules in the gut. Glucose is absorbed into the bloodstream, elevating blood glucose levels. The rise in glucose stimulates the secretion of insulin from the beta cells of the pancreas. Insulin is needed by most cells and facilitates entry of glucose into the cell, which then use the glucose for energy. The increased insulin secretion from the pancreas lowered blood sugar levels. If insulin production is decreased, glucose entry into cells will be inhibited, resulting in hyperglycemia or an increase of circulating blood sugar. The onset of type 1 diabetes is usually abrupt. It generally occurs before the age of 30, but may be diagnosed at any age. Concepts for type 1 diabetes. These are the two concepts I consider to be foremost. According to the concept of self-management, it is understood both as an educative process and an outcome. As an educative process, self-management includes participation in education designed to bring about specific outcomes, preparation of individuals to manage their health care conditions on a day-to-day basis, the practice of specific behaviors and the development of skills and abilities needed to reduce their physical and emotional impact of illness, with or without the collaboration of a healthcare team. Per Giddens, the concept of self-management can be defined as the daily maintenance a person must assume to regulate or reduce the impact of disease on health and range from a complete ability to self-manage to the inability to self-manage. The 5 key attributes of self-management are self-efficacy, which is the confidence in knowledge to reach desired outcomes. Patient engagement is a step past self-efficacy and is the knowledge, skills, ability, and willingness to be an active participant in their own care. Health education pertains to the learning of any skills or knowledge that is needed to assist in a caregiver with confidence to deliver needed care. Patient-provider relationships empowers the patient to take responsibility of their own care, and disease management, where the patients have sufficient knowledge, confidence, education, and signs and symptoms which allow the patient to maintain health within the confines of their disease process. Also, one of the concepts I considered high for diabetes type 1 is glucose regulation. The concept of glucose regulation is defined as the process of maintaining optimal blood glucose levels. Glucose regulation is achieved through the delicate balance between nutrient intake, hormonal signaling, and glucose uptake by the cells. Once glucose enters the cell, It is oxidized through the cellular respiration into adenosine triphosphate, or ATP. The efficiency of the glucose metabolism is reflected in circulating blood glucose level. Normally, this occurs without awareness of the process. This concept interacts quite closely with hormonal regulation. With insufficient insulin production or secretion by the beta cells of the pancreas, then the automatic process ceases, and we now must take steps to intervene in the process, and that step is the insulin replacement therapy. Hypo and hypoglycemia are complications of impaired glucose regulation. Signs for hypo include reduced cognition, tremors, diaphoresis, weakness, hunger, headache, irritability, and can even lead to seizures. And hyperglycemia include polyuria, polydipsia, dehydration, fatigue, fruity odor to the breath, Kurzweil breathing, weight loss, hunger, and poor wound healing, all of which Susie had. Additional concepts. So many of the concepts work in conjunction with one another. It's difficult to determine where one starts and one ends. This is just a few of the others that I felt related somewhat. Adherence to a strict regimen of diet, exercise, insulin therapy, and maintenance is imperative to maintaining health in the diabetic patient. Coping with the diagnosis to achieve self-maintenance and adherence. Family dynamics. Having a sick child can cause changes in the normal family dynamic for the non-diseased sibling and for the family at large, not to mention the isolation the patient might feel. Fatigue is a symptom of hyperglycemia. Functional ability. Not every child is ready to take on the needed skills to achieve self-maintenance. Therefore, a parent must step in to complete this until they are ready. Hormonal regulation. Because insulin is a hormone, it is closely interrelated with the concept of glucose regulation. Infection. Those with high glucose levels are prone to fungal infections. Nutrition must be closely monitored by the diabetic to maintain glucose regulation. And sensory perception. Unwanted side effects of high blood glucose for long periods can cause visual disturbances, diabetic retinopathy, and neuropathies. Sister Callista's Roy adaptation model. Most of my understanding of this model comes from the diagram, so look at that as I talk about it. Sister Callista's Roy adaptation model concentrates on the individual as a biopsychosocial adaptive system and defines nursing as a humanistic discipline which addresses the person's adaptive or coping abilities. Her model is based on adaptive behaviors which can be produced by varying the environment of the patient. In this model, it is believed that by modifying the individual and the environment, this can promote adaptation of the patient. Roy regarded the person as an adaptive system with psychosocial, self-concept, role function, and interdependent modes. She began the formation of her model when she worked in pediatrics and began to study children and speculated at their ability to readily adapt to physical and psychosocial changes and how it can be applied in the healthcare systems and all of our patients. So let's take a look at how this applies to Susie. It begins with the input or stimuli, which is broken down into three categories. Focal stimuli, which consist of internal and external stimuli that are challenging the patient, such as the turmoil Susie's body is going through trying to normalize her insulin and maintenance of glucose regulation. Contextual stimuli, described as all other stimuli excluding focal, counting all the stimuli around her, such as her illness, unknown environment of the hospital, and what to expect from a lifetime of diabetes. and the residual stimuli are unclear stimuli together with the environment factors that may or may not affect the patient. In Susie's case, is based on her family background and spiritual beliefs, how her life must change in order to maintain her health. The control process, the regulator, is described as the human body and how it responds through automatic and spontaneous human responses. So at this point, Susie's automatic glucose regulation system and insulin function are not operating appropriately. The cognator is defined as the mind and learned perceptions, judgments, and knowledge, which at this point, Susie is greatly lacking. She needs the knowledge to understand and care for herself. The effectors, which are listed as the 4 modes of the actual adaptive responses. Physical is how basic needs are met, such as through oxygenation, nutrition, elimination, activity, protection, and rest. And in Susie's case, nutrition is at risk, as is activity and rest. Self-concept is based on who one is and how they act in society. And this is a drastic change for Susie, who was just an average high school student and now has a chronic illness to deal with. Role function is considered primary, secondary, and tertiary of how the person performs in society. Susie, who has irregular meal times, frequent exercise without eating, and is a key member of her team, and although she can still play volleyball, she may have to make some other drastic changes in her life around her eating schedules and activity schedules. And lastly, interdependence is the interaction of a person in society, such as giving and receiving love, respect, and values. Her interdependence changes now as she may need to rely on her parents more to gain knowledge of medications, disease process, and nutrition. Her friends will need to know of her diagnosis to be available in the event of a hypoglycemic event. This is just a small sampling of the nursing diagnoses I came up with. Risk for unstable blood glucose related to insulin deficiency. Risk for fluid volume deficit related to osmotic diuresis. Altered nutrition, less than body requirements related to insulin deficiency, evident by recent weight loss. Risk for infection, high glucose levels, decreased leukocyte function, and alteration in circulation. Powerlessness related to long-term and progressive illness that is not curable, with reluctance to express true feelings, expressions of having no control or influence over the situation, or apathy, withdrawal, and anger. Ineffective self-management related to new onset diabetes, lack of knowledge about diabetes and its management, and risk for injury related to hyperglycemia, peripheral sensory neuropathy, autonomic neuropathy, immune system deficit, and vascular insufficiency. Did you know that insulin therapy is the only treatment for type 1 diabetes? There is no cure. Did you know about 80 people per day get diagnosed with diabetes type 1? The rate of type 1 diabetes incidence among children under 14 is estimated to increase by 3% annually worldwide. And did you know that type 1 diabetes accounts for $14.9 million in healthcare costs in the United States each year? And as I stated, there is no cure. So some humor in a non-humorous talk. Keep calm, carry a glucose meter, alcohol wipes, lancets, snacks, syringes, insulin, and glucagon. If anyone has any questions, please don't hesitate to ask. My contact email and phone number are listed below. And these are the references. I'd like to thank everyone for their attention in this matter, and I hope you learned something from this.